So again, when we say dyssynchrony, we mean dysfunction in the heart performing its function as a pump. So the main function of the heart is a pump, to pump blood. So like any other pump, pumps have to be efficient, because if pumps are not efficient, they're going to lose energy and they're going to be less effective. And the heart is no different. So the heart has to be an efficient pump. And when we do echoes and we look at the heart, we see in a normal heart, that is, we can see that the walls are moving in together. Okay, so if you can sort of look in your mind's eye, just look at a normal heart. It's the walls are coming in. So when we look at the parasternal long axis view, the septum moves towards the posterior wall, and the posterior wall moves towards the septum. In the four chamber view, the septum moves towards the lateral wall, and the lateral wall moves towards the septum. And that's a coordinated pumping function of the heart. And everything is coordinated in such a fashion that when the septum is moving inwards, the lateral wall is also moving inwards. So everything is coordinated. And by coordinating the motion of the heart, the efficiency as a pump is optimized. But there are some situations, and you guys do echoes, you have seen it all the time, where one wall is contracting, say coming in, and the other wall is moving outwards. So the overall efficiency of that heart, or that pumping function, is going to be reduced. Because if you want to maximize the pumping function, everything has to come in at the same time, so you can mobilize maximum amount of blood out of the heart. So when we say dyssynchrony, there is some abnormality in the synchronization of the heart as a pump. It's not pumping efficiently. And we can measure that because we have device that can synchronize the heart. Okay? So, of course, we measure the pumping function of the heart by the ejection fraction. And it's not uncommon to get someone who have dyssynchrony with ejection fraction of, say, 30%, and you put in a device to synchronize the contraction of the heart, and the ejection fraction moves up to 50%. So that is a practical way to demonstrate that you can increase the efficiency of the pump by synchronizing contraction. So first, we're going to look at the definition of dyssynchrony. I just explained it to you. And then we're going to look at the types of dyssynchrony, how we can use echo to diagnose dyssynchrony, and then we'll talk a little bit about therapy, okay? All right, so we've been saying, so when we say dyssynchrony, or another term for it is asynchrony, it's difference in contraction in the ventricles. So different parts contract at different times. So just look at it. I mean, for the heart to be very efficient, everything has to contract and move at the same time, right? If different parts are contracting at different time, then it's not going to mobilize maximum blood out of the heart. Okay, so that's the synchrony. And If dyssynchrony is present, then it's going to reduce cardiac efficiency and cardiac output. A practical way is just to do your echo pre and post. So if someone have dyssynchrony, and a very common patient who is going to have dyssynchrony is someone with a left bundle branch block. So if someone has a left bundle branch block in the ECG, that person is going to have significant dyssynchrony because the septum and the posterior wall is going to contract at different time. You want them to contract at the same time to pump blood out. If the septum contract and then a few milliseconds later the posterior wall contract, then you're not going to mobilize maximum amount of blood out of the heart. So we can synchronize that. So these are the different types of dyssynchrony. So we have atrioventricular dyssynchrony. And what we mean by that, so if you just go over the function of the heart, you know that blood, if you're on the right side, blood is going to enter the right atrium from the inferior vena cava and superior vena cava, right? So then the right atrium fills with blood. We know the right atrium, the tricuspid valve opens, blood rushes into the right ventricle, and then later on, the right atrium contracts and forces an additional amount of blood into the right ventricle. That's what's supposed to happen. But if you have some conduction problem, so think if you have some conduction problem and the time in between the atrial and ventricular contraction is off, then the atrium may contract and try to pump blood into the ventricle when the tricuspid valve is closed. And not only that, you can look at atrial fibrillation. With atrial fibrillation, the atrium is not contracting at all. Even atrial flutter. Atrial flutter is also a condition where the atrium and the ventricle are not in sync. So whenever the atrium and the ventricle is not in sync, that's what we call atrioventricular dyssynchrony, because the heart is constructed in such a fashion that the atrium has to do what it has to do, and then the ventricle have to do what it has to do. They have to work in concert with each other. They cannot be independent. Common thing is someone with complete AV block. So when you have complete AV block, the atrium is doing its own thing, the ventricle is doing its own thing. And those patients with complete heart block are very symptomatic because not only you have reduction in cardiac output because of that, but the atrium commonly contracts against a closed atrioventricular valve, say the tricuspid valve or the mitral valve, and then these patients will have a pounding in their head. So that's atrioventricular dyssynchrony, when there is, the time in between atrial and ventricular contraction or the normal synchrony between the atrium and the ventricle is not there. Because as we mentioned, if we look at the right side, the same thing happened on the left side. When the atrium is filled with blood, after the atrium is filled with blood, then if you're on the right side, the tricuspid valve opens. Blood's supposed to rush inside the right ventricle. And then towards the end, so that's diastole we're talking about now. And then towards the end of diastole, the atrium contracts. And that's the same thing happening on both sides, left and the right. But that's a coordinated and that's a very synchronized thing that's happening right there. If something is off, then you will get atrioventricular dyssynchrony. Okay. Now, there's another type of dyssynchrony. Okay. There's another type of dyssynchrony we call interventricular dyssynchrony. And if you think about it, you will get it. Again, the heart works in a very coordinated fashion. Everything about the heart is supposed to be coordinated. If it's not coordinated, then things are going to be off and the patient's going to be symptomatic, and you will know. We know that on the right side, the right ventricle supposed to contract and pump blood into the pulmonary circuit, the pulmonary trunk, the right and left main pulmonary arteries, and those arteries are going to take blood to the lungs, deoxygenated blood to the lungs. The blood is going to be oxygenated, and then it's going to travel through the pulmonary veins. From the pulmonary veins, the pulmonary vein is going to empty into the left atrium, and then the left atrium will fill with blood. Then the mitral valve opens, blood gushes from the left atrium into the left ventricle. Towards the end of diastole, then the left atrium contracts and forces an additional amount of blood into the left ventricle. The right ventricle supposed to contract a little bit before the left ventricle, and that is a coordinated thing. So you need for the right ventricle to contract a little bit before the left ventricle. So if there's a difference in timing between the right ventricular and the left ventricular contraction, that's what we call interventricular dyssynchrony, because you have to synchronize everything. Okay, so remember when we look at constrictive pericarditis and we see, they're interdependent. And if you remember the septum moving from one side to the next, depending on which ventricle is contracting. So if there's a difference in timing between the right ventricular and the left ventricular contraction, that's what we call interventricular dyssynchrony. So everything about the heart is supposed to be coordinated. So though what we mentioned before, two types. But usually when we talk about dyssynchrony, we're really talking about interventricular dyssynchrony, where you need to know that there are other types. So intraventricular dyssynchrony, and we usually reserve that for the left ventricle mainly, because the left ventricle is the main pumping chamber of the heart, because it's going to pump blood throughout the body, oxygenated blood throughout the body. So when we talk about dyssynchrony, we usually means intraventricular dyssynchrony and left ventricular intraventricular dyssynchrony. So look at the left ventricle. Just look at the left ventricle. Again, the heart is a pump. So if it's going to pump, all the walls should be coming in at the same time. You don't want a situation where one wall is coming in and the next one is going out. It's not going to pump adequate or a significant amount of blood out by doing that. So when the patient comes to the cardiologist, you have to diagnose dyssynchrony, because if you have intraventricular dyssynchrony, you already know that the heart is not going to be efficient. The pumping function of the heart is not efficient if you have dyssynchrony. So usually patients if you look at the ECG, if the QRS is greater than 120 milliseconds, you can bet the patient is going to have some amount of dyssynchrony. Usually patients with left bundle branch block and QRS like 150, 160 milliseconds, those patients usually have dyssynchrony. Okay, we can use the M mode to look at to diagnose dyssynchrony. The Doppler, we can use the Doppler as well, the myocardial velocity. Remember, we did that when we did strain and strain rate. And usually, if the patient have a very low ejection fraction, you can bet you're going to have dyssynchrony. So the walls are not going to have this coordinated contraction that we talk about. So this is using the M mode, and I'm not going to go into too much detail. I just want to show you that. Okay, so this is a short axis view, and at the level of the papillary muscles, and this is your cursor, and then this is the M mode representation. So you can look at the structures that your cursor crosses. It crosses the chest wall, okay, the chest wall right there, and then it crosses the pericardium, then the RV wall. So right up here is the chest wall and all that's all the good stuff. Then you have this is the RV wall right here, the right ventricular wall. Okay, below that, this is your right ventricle. Okay, the same structures that the cursor sees. That's okay, and then this is the septum. This is the ventricular septum. So this is your ventricular septum, and then this is the ventricular cavity. So this is the ventricular cavity, and then this is the posterior wall. So this is your M mode representation of what's up here. Now, if you look at the septum, so what we said is when the heart pumps, the septum should move towards the posterior wall, and they're supposed to come in together. So if you were if they ask you in the exam to use a diagram to show a very efficient heart, so I'll put my septum coming down like this, okay, and it's gonna be systole, and I'll put my posterior wall like this, okay, in systole. Okay, you want to make sure the septum comes to meet the posterior wall. They're supposed to come together in systole because they're pumping. That's how you're going to pump. Okay, so this will be systole, and then this will be diastole when they relax to fill with blood. Okay, now if you look at your septum right here, this is the septum, and this is the posterior wall. So if the septum is going to contract, so it's going to fall towards the posterior wall, you're going to see the lowest point of the septum. The lowest point of the septum is right here, right? Or if you go over here, it's right there. This, so the lowest point of the septum, that's when it contracts and it's moving towards the center of the cavity. And the posterior wall should do the same thing. So if this is your maximum point of descent of so this is the maximum descent of the septum. All right, and then this is your posterior wall. The posterior wall in systole should move up towards the septum. Okay, so it's moving up, moving up. The maximum excursion of the posterior wall is about right there. Right? What's the problem? The problem is when you have maximum contraction of the septum, that occurs sometime before you have maximum displacement of the posterior wall. Okay, so this maximum displacement of the septum should coincide with the maximum displacement of the posterior wall. But there's a delay. There's a delay. Okay, so when you have your maximum displacement of the septum, you have to wait a little time before you have maximum displacement of the posterior wall. So we call it a septal to posterior wall motion delay. They're supposed to coincide together. It's supposed to be right there. If it was an efficient heart, it would be right there. Okay? They should occur together. But the mere fact that you have maximum contraction of the septum and then you have to wait 180 milliseconds later to get maximum displacement of the posterior wall, it's telling you that there is there's some dyssynchrony. The contraction is not coordinated. Okay, so you can use your MO to look at septal to posterior wall motion delay. Okay, so you can use your MO to make that assessment, and that's how you do it. Okay, you can also use color. You can also use color to 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 look at it. So again, your transducer is right there. So when you have, if there's motion towards the transducer, it's going to be in red. If it's away from the transducer, then it's going to be in blue. Okay, so when 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 the septum contracts, okay, so the junction between the blue and the red, that would be systole, and then the same thing for the posterior wall, and you get the same delay. All right. Okay. So if you're going to use M mode to look at dyssynchrony, and you're using septal to posterior wall delay, again, you're supposed to use your short axis, or you can use the power sternal long axis. You're going to adjust your sweep speed to about 50 to 100 millimeters per second, and you're going to look the time delay from the peak inward uh, posterior wall to just as I show you, where you have maximum displacement of the septum, you're going to do a perpendicular, and then where you have maximum displacement of the posterior wall, you do the same thing. And anything greater than equal to 130 milliseconds indicates that there is some left ventricular dyssynchrony. Okay, so using M mode, you can do that. You can, if you're looking for interventricular mechanical delay, you can just use your Doppler. Okay, you can use your Doppler. You can what you're going to do, you're going to do your right ventricular flow uh, uh, envelope. So you're going to do Doppler across the right ventricular outflow. So when you do your Doppler across the right ventricular outflow track, then you're going to match everything up to the ECG. So from the onset of the QRS to where you have ejection across the pulmonary valve, this would be your IVRT, right? Sorry, this would be IVCT. IVCT, remember IVCT, isovolumic contraction time, and then you have the ejection. So this would be your IVCT across the pulmonary valve. And then you do the same thing. This is the left ventricular flow track, okay? And then this is going to be IVCT. So isovolumic contraction time, then the aortic valve opens, then you have ejection across the aortic valve, then this will be your IVRT right there, okay? But this is the IVCT for both, okay? Now, If the difference is more than 40 milliseconds, it indicates dyssynchrony. So if your IVCT for the right ventricular flow tract, and you know this, right? This is just put your Doppler across the pulmonary valve, and you get ejection across the pulmonary valve. But before you get that, you're going to get your isovolumic contraction time, and then you get your IVRT. Okay, and then you do the same thing for the left ventricular flow tract. Okay, you get your isovolumic contraction time, then the aortic valve open, blood is ejected across the aorta. So the difference in these two times, if they're more than 40 milliseconds, it indicates LV dyssynchrony. And again, sweep speed 50 to 100 milliseconds, and supposedly. You can also use your 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 strain. You can use strain, and you say you want to look at. So this is the apical four-chamber view, and you want to look at the septum and the lateral wall. Again, remember, when you have contraction, the septum's supposed to move inwards, the lateral wall's supposed to move inwards, and they're supposed to move inwards at the same time. So you can do a strain analysis of the septum right there. You can do a strain analysis of the lateral wall. Superimpose them. Okay, the peak's supposed to occur at the same time. So this is what this. So this is a normal uh, heart or normal. There's no dyssynchrony here because you have peak velocity. So the septal strain is in red, lateral wall strain is in green. So the peak occurs at the same time, which is different from if you look at over here now. You're still looking at the septum and the lateral wall. Septum is in yellow, but the septum peak is right there. Lateral wall peak is right there. So they're not contracting at the same time. Okay, so you can use strain to look at dyssynchrony. So you can see that there's a time delay between the peak systolic velocity. The peak systolic velocity is supposed to superimpose. There's a difference. Okay? So if the septal to lateral wall peak systolic velocity is the time difference is equal to or more than 65 milliseconds, that also indicates dyssynchrony. So all the methods that we have used show that you're supposed to have a contraction occurring at the same time. So if the contraction is not occurring at the same time, that's when you have dyssynchrony. And whatever velocity curve you're going to use, the same thing. The peak is supposed to occur at the same time. Okay? So, this is a different type of velocity curve, but you see one peak is there, the other peak is there. They're supposed to superimpose. And the same thing, one peak is there, that is there. So they're not superimposed. Okay? So when you see something like that, that's dyssynchrony. Okay, the peak's supposed to occur at the same time. And let's just go back. All right. All right, so we use speckle tracking to do our to look at our strain and strain rate. All right, so if you have dyssynchrony, what are you going to do about it? What are you going to do about it? So the heart is not contracting in a synchronous fashion, and as a result, the efficiency of the heart as a pump is reduced. So we have something called CRT, cardiac resynchronization therapy, and it is it's a device. It's a pacemaker device that allows the septum and say the posterior wall to contract at the same time. So you're gonna do the adjustment yourself. And you must have heard about biventricular pacemaker. So what we do is we put a pacemaker lead in the right ventricle, and then we put a pacemaker lead, okay, I'm going to say in the left ventricle, not really in the left ventricle, but that's the idea. If you can get a pacemaker lead in the right ventricle and you can get a pacemaker lead in the left ventricle and you stimulate them at the same time, then you can coordinate the contraction. So that's what we call a bi-V pacemaker. And the FDA as a I think it's a class 1 indication. Uh, Patients with ejection fraction of less than 30% uh, should have a biventricular pacemaker. Remember what we said before, once the ejection fraction is pretty low, you're going to have some amount of dyssynchrony, and the efficiency of the heart as a pump is going to be reduced. So if your ejection fraction is low, it's less than 30%, and there are recent studies showing that even ejection fraction of 50%, those patients may benefit from a biventricular pacemaker. So again, the idea is to get a pacemaker lead in the right ventricle and to get a pacemaker lead somewhere in the left ventricle. We cannot put any type of hardware in the left heart. We cannot do that because it will clot. Those clots will break off and travel to the brain. The patient will get a stroke. They'll get blood clot going to the bowel. They'll have ischemic bowel, and so we don't do that. So what we do, if it's going to be done percutaneously, we put the lead in the coronary sinus because the coronary sinus sort of wraps around the left ventricle. So we can put a lead, and we usually do that. So we put a lead in the coronary sinus, which wraps around the left ventricle. But we can also do what we call epicardial leads, where we open the chest. We don't have to open the chest to any large extent, but we open the chest and we put a lead on the left ventricle, directly on the surface of the left ventricle, so we can get uh, depolarization and contraction of the left ventricle. And we did a case earlier this year at one of the facilities. We actually did the epicardial approach, and it's quicker. It's quicker than the percutaneous approach to try, because sometimes it's very difficult to find the coronary sinus and to get good position in the coronary sinus. So you could quickly open the chest, very small incision, and you can you use a scope and you identify the surface of the left ventricle and you just screw the lead right there. So, but the important thing is that you need a biventricular. We say biventricular because you have a lead in the right ventricle, so you can stimulate the right ventricle, and you have a lead in the left ventricle, so you can stimulate the left ventricle, or you have a lead on the surface of the left ventricle, or close to the left ventricle, so you can stimulate the left ventricle. You want to get those stimulation approximately the same time. You want to coordinate the contraction uh, of both the right and the left ventricle. Okay, um, so that's CRT. So in the United States, if once the patient have a ejection fraction, say 30%, if you don't get them a BiV, as a matter of fact, they need something else, not only a BiV pacemaker, they need an ICD. So if you don't get them a BiV ICD, that's malpractice right there. So you have to give them resynchronization therapy and ICD. And what we do in the echo lab to make sure that you optimize resynchronization, you can look at the mitral inflow, and you want to optimize to get a nice crisp E velocity and a nice A velocity. And when you look at the ECG, your mitral inflow should uh, be in diastole. Okay, you don't want something looking like this where the A look like it's truncated because it's now going outside of diastole, and then you don't want to get something looking like this. So you want to make sure you adjust it just right. Okay, so we talk about AV optimization. So you can you make your adjustments, and okay, so this is not a good optimization because you don't have any, your A wave is absent. So you and then this you don't want to this if this is what you get in your merge in your E and your A. So you want to do your adjustment, and then you can look at your you can look at your mitral inflow and see where you have optimization of your thing. And it's not uncommon. This is before synchronization. When the heart is dysynchronous, you have a lot of mitral regurgitation. But when you coordinate contraction, then because now you increase the efficiency of the heart as a pump, and things are contracting at the same time, you can reduce the amount of mitral regurgitation that you have. Look at that. All right. So in essence, you have to be aware that you can use echo to help with synchronizing uh, contraction in the heart. Echo is a very good tool to look at the heart and say that you have dyssynchrony. For the mere fact that if your ejection fraction is less than 35%, more than likely the patient have dyssynchrony. Where you can use the M mode, you can use, you know, the velocity strain. You can use those velocity to show that there's dyssynchrony. There's a difference in contraction in the different parts of the heart. The contraction is supposed to be coordinated. So you can use the echo to show that there's dyssynchrony. And then after the patient has cardiac resynchronization therapy, you can show that the ejection fraction goes up, things like mitral regurgitation get less, and the patient usually become less symptomatic As a matter of fact, there are some studies that show that there's improvement in mortality in these patients, and especially if they have ICD in place, defibrillator. So that is Dyssynchrony in a nutshell. You can read up some more about it.